Time to continue on our road trip through the anemias. In the previous sketch, we went storm chasing and witnessed the violent, awe-inspiring power of the spleen, devouring any red blood cells in its path. Well, mostly damaged or malformed ones. This is called extravascular hemolysis, because the RBCs are shredded in the spleen, instead of the vasculature. Well, in our next scene, we're still shredding cells, but this time, we're right out there in the circulation. Out there on the open road, all alone. Helpless. Really not a good time for your car to break down. And I know we're in black and white, but imagine those tires are busted red blood cells. And when RBC death occurs inside blood vessels rather than in the spleen, it's called intravascular hemolysis. When this happens, RBCs spill their contents out into the bloodstream, creating many of the classic symptoms and signs that are unique to intravascular hemolysis. First, in the trunk, you'll notice dehydrated milk falling out of those grocery bags. That's lactate dehydrogenase, leaking out of lysed red blood cells. So when your labs come back, look for an elevated LDH. Also, you see those hemoglobin hubcaps? The contents of RBCs include lots of hemoglobin, of course. Therefore, with hemolysis, serum levels of free hemoglobin will increase as well. Haptoglobin, a protein normally found in the bloodstream, binds to some of this free hemoglobin. The haptoglobin-hemoglobin pair is taken up by macrophages in the liver and cleared from the circulation. Thus, haptoglobin protects the body from oxidative damage done by all that heme. So we've attached a few of the hemoglobin hubcaps to the haptoglobin happy stay sign. And in true dramatic irony, the sign is decaying. So remember, as hemoglobin binds up all the haptoglobin, serum haptoglobin levels decrease to low or undetectable levels. Because hemoglobin is so small, some free hemoglobin slips right through the glomeruli of the kidney and into the urine. This is called hemoglobinuria. In the urine, hemoglobin degrades into heme or methemoglobin. These dark pigments turn the urine a brown color. Note, too, that myoglobin released in the setting of rhabdomyolysis can produce a similar color in the urine. Sometimes, all the heme released from lysed red blood cells gets trapped in the nephron of the kidneys, where it plugs up the convoluted tubules, constricts blood flow, and causes damage. In cases of extreme hemolysis or in patients with pre-existing kidney dysfunction, this damage can lead to acute tubular necrosis, abbreviated ATN, one of the forms of acute kidney injury, or AKI. At Sketchy, acute kidney injury is represented by a broken kidney-shaped window, like that rear window on the house in the back. ATN is symbolized by a rusty necrotic drain pipe, sloughing mud and leaves just like the classic muddy cast seen on urine sediment. Check out our acute zombie necrosis sketch for more info on ATN. In short, acute kidney injury manifests as an elevated BUN and creatinine, and kidney irritation can present as referred back pain, usually in the flank area. Ah, I see. Here's the cause of the accident. Mere coincidence? Or preconceived goat attack? With or without haptoglobin, hemoglobin will eventually be broken down into its component parts, heme and globin. The metabolism of heme eventually leads to unconjugated bilirubin. At Sketchy, unconjugated is symbolized by an unleashed billy goat without a collar, out in the circulation wreaking havoc. Remember, increased serum bilirubin leads to the clinical signs of jaundice and icterus. His little pee-pee friend there is urobilinogen. We covered him very briefly in the previous sketch, so to summarize, more bilirubin in the blood means more excreted in the bile, leading to more converted into urobilinogen in the GI tract, which means more is reabsorbed from the GI tract, leading to more urobilinogen excreted by the kidneys right into your pee. So expect to see increased urobilinogen in the urine and stool. It just means you have too much bilirubin floating around in circulation, so it gets excreted. I think now is a good time to mention the birds as well, which have been gathering eerily in large numbers recently. When bilirubin reaches the liver, it's conjugated, processed further, and then kicked out into the bile. If the bilirubin gets too saturated, it can precipitate into pigmented gallstones that can lead to biliary colic and cholecystitis. And by now you should know that at Sketchy, when you see the seagull, think seagull. Oh my god. Where did that guy come from? Giving me some serious heebie-jeebies. Oh, just the motel owner. It's all good. See that tea bag? In the face of accelerated red blood cell destruction, another lab value you should look out for is the reticulocyte count. The reticulocyte count reports how many new immature red blood cells are getting pumped out of the marrow as the body attempts to replace all the blood cells getting lost. The retic count should increase somewhere above 3%. We've chosen a tea bag because reticulocytes are large round cells that contain a characteristic net-like chromatin, as opposed to mature RBCs, which have no nucleus. Hence the net-like tea bags. Plus, a tea bag is kind of like premature tea. Gotta let that thing steep. On the peripheral smear, reticulocytes are larger than RBCs, lack that central pallor characteristic of RBCs, and stain a mottled bluish-purple because of all that chromatin. Now, I mentioned at the beginning that we're still in normocytic territory here, so I'd like to introduce you to Norman Bates. Normocytic is defined as a normal mean corpuscular volume, somewhere in the range of 80 to 100 femtoliters. Watch out though. Hemolysis is sometimes associated with macrocytosis because of those reticulocytes, which are larger than mature RBCs. Not only that, the MCV can be low, normal, or high depending on the degree of hemolysis and reticulocytosis. So, like I've said before, while not technically normocytic 100% of the time, at least rest assured that on test day, intravascular hemolytic syndromes will most likely not produce a substantial change in that MCV value. For the rest of the sketch, we're going to focus on a 1 in a million diagnosis. Literally. Paroxysmal nocturnal hemoglobinuria, abbreviated PNH. And, well, I guess we have to stay for the night. Looks reputable enough. PNH is the result of an acquired mutation in the PIGA gene on the X chromosome. Think PIG-A along with the X-shaped structure underneath. PIG-A stands for phosphatidylinositol glycan anchor gene, and it codes for the first step in the production of glycosyl phosphatidylinositol proteins. GPI is an anchor protein that holds many other proteins to the surface of the cell. A couple important surface proteins that the cell loses are the complement inhibitor proteins CD55 and 59, symbolized by the Route 66 signs falling off their post, worn away a bit as well, to represent the numbers 55 and 59 specifically. Without CD55 and CD59 anchored to the cell, complement activation runs rampant. Complementary breakfast. See what we did there? Membrane attack complexes begin to attach to the cell, causing significant damage. Intravascular hemolysis of RBCs by MAX leads to clinically significant anemia and hemoglobinuria. And, well, all the signs and symptoms we discussed earlier on in the sketch. Okay. Getting some serious vertigo up here. Okay, that's better. It doesn't stop there, though, because these anchor proteins are normally present in all hematopoietic cell lines. Patients with PNH can suffer from destruction of white blood cells and platelets in addition to RBCs. This leads to a pancytopenia, symbolized by the empty room service PAN. The strong association between PNH and pancytopenia is unique among the hemolytic anemias. Well, looks like somebody else is staying here. Not completely abandoned. Good sign. Just take a look-see here. Ugh. We all knew this one was coming. It's the classic presenting symptom, nocturnal hemoglobinuria. It's the result of a mild respiratory acidosis that all of us experience when we're asleep. At Sketchy, we depict respiratory acidosis by showing someone breathing into a paper bag, increasing that CO2 and decreasing that pH. In patients with PNH, that slight nighttime acidosis is enough to promote complement activation, membrane attack complex formation, and hemolysis. As a result, some patients will report dark urine when they first pee after they wake up. Little tip from the pros, by the way. If you're filming in black and white and you need to show a puddle of dark urine, all you need is a little chocolate syrup. The last complication of PNH is the most deadly. Due to a reason still unknown, patients with the PIG-A mutation are much more likely to have thrombosis, especially in the abdominal and cranial veins. We think that complement activation plays a role in promoting clot formation, but again, this is not well understood. Diagnosis of PNH is confirmed by flow cytometry, looking for a deficiency of CD55 and CD59 proteins on cell surfaces. Just think of this water meter, measuring the flow. Since PNH is an acquired, not congenital condition, the The classic presentation is an adult with fatigue, anemia, possible leukopenia or thrombocytopenia. Remember, there could be a pancytopenia going on, as well as symptoms and signs of a large vein thrombosis, such as a hepatic vein thrombosis or cerebral venous sinus thrombosis. Well, I've had about enough of this place. So let's sum this thing up, shall we? With paroxysmal nocturnal hemoglobinuria, it's all there in the name. Paroxysmal, sometimes, nocturnal, at night. And hemoglobinuria, red blood cells getting slashed. Paroxysmal nocturnal hemoglobinuria is an acquired defect in PEG-A, which attaches GIP to the membrane of blood cells. The loss of GIP means no CD55 or 59 around to fend off the complement cascade MAC slasher, leading to intravascular hemolysis at night when slow breathing creates a bit of respiratory acidosis. As with all intravascular hemolysis, expect to see elevated unconjugated bilirubin, hemoglobinemia and hemoglobinuria, and decreased haptoglobin, which gets used up shuffling free hemoglobin to the spleen. All this stabbing of the red blood cells leads to a normocytic anemia, MCV of 80 to 100, with appropriate reticulocytosis, greater than 3%. That T, remember? And even though it's black and white, look for the classic signs of jaundice and icterus. And if severe enough, kidney injury and even ATN from heme-induced damage to renal tubules. Diagnosis is made by demonstrating the lack of CD55 and 59 on flow cytometry. But the most feared complication isn't bleeding or anemia at all. It's thrombosis of the visceral and cerebral veins. So, watch yourself at night around here. And maybe just shower in the morning. Or never.